That's better than like, yeah. Levi got taken out by the lift chair. Chewy was not moving fast enough, so he pushed Chewy back and he wouldn't get hit. And then I turned around and I was waiting for
But to their defense, because I mean, it is like, we've asked about this in task force before, why?
Good morning, everyone. We'll give everyone just a few more minutes to hop on and we'll get started right at noon. Thanks for joining. All right, I have noon, so we'll go ahead and get started. Thank you all for joining our final sepsis cohort session. My name is Amber Kavan, and I work with the Nebraska Hospital Association on the H-Quick project with Dana and Margaret. If you wouldn't mind just muting yourself for now, we will have an open discussion later on, so feel free to unmute yourself at any time, but just to eliminate some of the background noise, please be muted for now. And if you wouldn't mind also chatting in your name and organization to help with attendance reasons, we'd appreciate it. So today we're excited to hear about everyone's success stories related to sepsis care in your organizations, while also addressing any of the barriers you may have encountered during this project. Today, like I said, will be open discussion, so please unmute yourself at any point in time to share your stories or anything you'd like to share with the group. You can also use the chat feature if you'd like. So with that, we'll go on to our objectives. Today, we will review our participant gap analysis responses that everyone completed prior to starting this learning cohort. We're going to discuss some progress made towards sepsis programming goals that may include your aim statements, benchmarks, and your PDSA cycles that you've been working through. We want you to share your successes as well as barriers, and then we will also define additional support needed, as well as some upcoming training opportunities, as well as next steps and follow-up. So about the sepsis learning cohort, we have 72 total hospitals in our HQuick project. That includes 65 CAUS and 7 PPS hospitals. And for this sepsis learning cohort, 21 hospitals enrolled, and 19 of you completed that initial gap analysis that we'll review here shortly. So just to remind the group of one of our main HQuick program goals and why we work through projects like this, we want to increase patient safety, reduce patient harm, and improve outcomes across Nebraska. So we appreciate all of your efforts on quality improvement throughout the state. So now we're going to quickly go over the data pulled from the gap analysis. First up is leadership support. We know how important it is to get that support and buy-in from your leadership team, as well as your medical staff team on any quality improvement project, not just sepsis. So the majority of you report that yes, you do have the support and needed participation for sepsis-related care, but several of you may not utilize a multidisciplinary team to discuss sepsis during your meetings. I love how many of the organizations responded yes, that their sepsis care aligns with their hospital's quality, safety, and organizational goals. So I think that that's wonderful and something to highlight at this time. Moving into committees and whether or not you report on sepsis care to these groups, 13 of the 19 respondents do report to their quality committees. 10 out of 19 report to their infection control committees, and 11 out of 19 report to their medical staff committees. And I know that in small hospitals, oftentimes the same people are involved in these committees. So finding what works best for your team is important to note. Early identification in sepsis and infection risk. 100% of the respondents reported that yes, they do have protocols in place for sepsis screening. However, about half noted that they are beginners or their process needs improvement. Most reported that sepsis bundles are utilized, as well as order sets within the EMR. However, several noted there is also room for improvement there. The next slide reflects infection and sepsis risk assessments upon admission, as well as care planning around sepsis care during the hospital stay. The majority of respondents reported that they do not care plan around sepsis or infection risk, and a good chunk of organizations do not include this in their admission assessment. So I'll be curious to hear some stories that you may have related to this and care planning with your sepsis patients here shortly. The next slide addresses treatment and bundle implementation. So most organizations noted that yes, you do have order sets and sepsis documentation tools available. And we talked a lot about this throughout our sessions, but over half of the respondents thought that there may be room for improvement. So I'm glad that our sepsis experts that shared their stories and processes for improvement were able to address these. And I'll be curious to hear some of the success stories here shortly. Because as quality leaders, we know that we can build and provide as many tools as we'd like, but if they're not utilized, or that frontline staff and providers don't think they're user friendly, our quality improvement efforts aren't going to be successful. So finding what works best for your organization is really important here. Education seemed to be one of the largest gaps across organizations. So whether it's educating your staff regularly, annually, or training your frontline staff on that early recognition of sepsis, we will provide you with some key resources at the end of our presentation to review and take to your nurses meetings or your staff meetings to help with this process, which also leads me into the patient and family education. And this seemed to be a big gap as well. So again, you'll find some great resources that you can print off for your patients and really include the patients and family in their sepsis care while they're in the hospital. So with that, I'm going to pass it off to Dana, and we'll discuss further some sepsis successes.
All right, thanks, Amber. And we are buzzing through this so fast. You guys are going to get a short day, it seems like. So I'm hoping you guys have some stories to share so that we can kind of have a little bit of a chat time. But so basically what we kind of were looking at for beginner, intermediate, and expert in your sepsis care are noted here. So as a beginner, we'd really like to see you, if you don't have anything, figure out how you want to screen for sepsis. And starting in the ED usually is your key spot, especially in rural healthcare, as a lot of those more critical patients we ship. So if you think about in a CAH, if you have someone come in showing some signs and symptoms, just being able to have a standardized way of screening and everybody on your staff knows that and does that for patients that exhibit certain signs and symptoms. So early identification, as we know, in so many things, but sepsis especially is very important. And then the last thing, and Amber spoke to education a little bit on those other slides, an annual sepsis education to all your clinical staff. It doesn't have to just be nurses, it doesn't have to just be ED staff. It can be everybody. And really, sepsis is becoming more and more prevalent, but we don't see it every day by any means. So just to have that annual overview, make sure we're updating what evidence is showing. As we know, medical care is changing each day. So just some sort of an annual sepsis education to keep it front of mind and make sure that all of your staff are saying the same things, doing the same things, and have a consistent process. So that's kind of those first couple steps to creating a sepsis program that we'd like to see a beginning hospital implement. And then as you step up into intermediate, developing a little bit more of the bundle or the protocol type of work is important. So again, we speak a lot to CAH hospitals because that's the majority of our audience. But really looking at that 1 hour sepsis bundle, including some of the standing orders for if they do screen positive for your sepsis screen that you implemented as a beginner. So those key things that we need to get started right away as we are looking potentially to transport, or if you're going to admit, just the key things that are time sensitive that need to get going to improve the outcomes of that patient. And those are things that we've talked about in our previous, Andrew spoke to those in his presentations, a lot of things about those key indicators and the time sensitivity of those. So, and then it's really important too from those to be tracking your time to get the bundle implemented. So getting the screening performed very quickly, where are we documenting our screening, and then really, are we getting those interventions started within an hour? It's really important to know your time zero for your patient, and make sure that's something all your staff does consistently, and then getting those interventions put into place. And then finally, as we move into that expert model, and obviously there's more that will go into a sepsis program. These are just kind of some key indicators that we discussed. So that expert level is really to create some collaborations with your other healthcare facilities. And I would say in your community, but this could also be in your surrounding region. I know a lot of critical access hospitals have a support system with maybe a skilled nursing facility in the next community or something like that. But that's another thing. If you get a call from that skilled nursing community about a patient that has something going on, if they're trained the same way as your staff is trained, it helps with that continuity of care. It helps really get a better picture of what the patient has going on. And then another piece of kind of creating that expert level is stratifying sepsis data. And it speaks here to the real data, which is also important. But sometimes as we look at rural patients in small towns, our real data is pretty bland and our demographics are pretty standard. So there are some other things that you can stratify data related to. I mean, age is obviously going to be a big one, but just looking at your data and trying to better understand maybe where there might be a gap in care, a gap in education. A lot of times we talk not only about educating our staff, but also about educating the community about what signs of sepsis are and when it is really a medical emergency to take care of that. So I think as we look at this, there are so many pieces to building a sepsis program, and just starting somewhere as a beginner and then filling in those gaps as you move forward until you have a really robust plan in your organization. Next slide. Well, actually, let's stop there. For those of you on the call, would you chat in whether you think you have nothing, maybe you're a beginner, and we go back to that one, Amber, sorry, I tricked you, an intermediate or an expert, and then maybe just a little note, or you can unmute and talk, that'd be great too, but you don't have to. Just put in the chat if you feel like you have nothing, you're a beginner, you're an intermediate, or you're an expert, and maybe a little bit about why. Would anybody be willing to? Rhonda says they're a beginner, and she's Perkins County and Grant. So Rhonda, do you have a sepsis screening process right now? Oh, she must not have heard me.
Hi, yes.
Anybody else?
Can you hear me?
Hi. Yeah.
We actually kind of have bits and pieces of the beginner. I think it's a matter of just more education with more, practice for what we really need to do. We have somewhat of a screening process, but it doesn't take you to the next step as far as what to do and the time piece of it.
Okay, very good. Thank you for sharing. I saw that York said intermediate to expert. Do you want to share a little bit about what you guys are doing?
Yes, this is Jenny from York General, and in 2020 through just part of 2021, we utilized the Nebraska Hospital Association sepsis gap analysis and went through that, and we actually had only identified we had 2 things in place on the gap analysis. So we spent a full 12 months, and we had a committee that was reported up through our Patient Care Quality Improvement Committee and to our medical staff of how we could move the no's on the sepsis gap analysis to yes. And so we implemented order sets, education, a newsletter, just lots of the different things around the sepsis gap analysis. And then started to look at in summer of 2021, we started to look at patient outcomes kind of to get our baseline. And we were not meeting our criteria as far as patient, patient care. And so we kept working with our medical staff and our nursing staff. And now we've started tracking outcomes at the beginning of our fiscal year, which was in October 1st. And we feel like right now we're probably at about 85% of the time we're meeting our all care measures met. So, and then we have a long-term care facility and an assisted living facility that we've done some education with that staff as well as far as recognizing maybe early sepsis and working with them. And the only thing I feel like we haven't done is stratifying the sepsis data using race, ethnicity, age, and language categories and like that. So it's been it's been rewarding to see us kind of like we didn't have anything in place and to where we are now. And really the staff have taken, our nursing staff in the ER and the medical staff have taken ownership into saying, okay, here's time 0, we got to go. And let's get this going. And it's part of our overall organizational quality initiative. So we'd be happy,
Awesome.
If anybody wants to reach out to me, I can put my email in chat and see if there's anything we can share with you. I'll just put that in there and you can email me. And if there's any questions I could share.
Oh, I love that. Thank you. That would be awesome. And I love that you use the NHA gap analysis. We worked really hard on that. It was like this huge project. So that makes my heart feel full.
Yes, we gave all of the members and all the medical staff we gave them the books that it came out in, and we utilized that information in there to, as a really a beginning to like our sepsis, like our worksheet that our nurses use, and we just modified it to make into kind of our own wording here and like that. And then our multidisciplinary team that we had we met every month and reviewed the information and like that. So we had great ownership, and that felt really good too. And was actually kind of a nice, I guess, thing to do instead of just everything was on COVID, you know, type of thing too. I think it was a little bit of a distraction to work on something else. So.
Absolutely. And I think too, it just feels good when you see a project kind of not closed because it's not over, but you feel like you really reached what you meant to, and really, you know, that kind of closure piece. So that's really awesome. Congratulations. Good job.
Yeah, it's been nice with, actually the VA reached back out to, our ER provider on a patient that we had like early recognition of sepsis, and reached back out, and they're like, you guys did a phenomenal job recognizing it, intervening, acting before we even transferred him to them. And I think we've really, you know, in our small hospital, we don't see a lot of people that get full blown sepsis, but I think we are recognizing, intervening, and hopefully making it so they do not become septic. So that's been the rewarding part for all of our team to see that happen. So
awesome.
Thank you.
Good, thank you. Yes, and I agree. I think that's kind of those, you know, early recognition, early intervention in the small hospital to hopefully either lessen the likelihood of them getting the full-blown sepsis, or, you know, moving beyond where they already are. So I think that is so true. That's awesome. Diane says, Harlan County, they're part of a beginner and intermediate. Do you want to share a little bit about what you're doing, Diane?
I knew you were going to call out data. Well, we have a sepsis screening protocol that is actually part of our EHR. So all of our ED and any patient that we put in automatically does get screened. I could do better with annual sepsis education. We do use Relias, and I'm just sitting here thinking maybe I need to look at something on there besides all of our other daily stuff that I educate. We do not have any standing orders at this time. We have samples and we look at them, and then we kind of get pulled another direction. I guess there's no excuses. I am tracking the sepsis screening. Is it being performed and documented? We use Action Q for our quality measures, and I was actually able to implement that right as a performance measure on Action Q. So we're doing a little bit of both.
Very good. And tell me what EHR you use, Diane?
We're on Meditech.
Meditech. So is that a built-in screening or something that you guys created?
You're going to ask
Or
the
do you
wrong
know?
person on that.
Oh, that's okay. I just thought maybe it was something that's okay. No big deal. Thank you.
It's not anything that I helped build, but we did our initial Meditech build with 2 other hospitals. So I'm thinking that it's something that somebody spoke up and said we needed to build in there.
Good. Thank you. Kaylee says they're a beginner. Do you want to share anything more from is that something you guys have started recently? Is it?
Sure. Can you hear me?
Yep, sure can.
So we were having some problems with like communication from the ER to the med surg, missing lactic acids. So I would call us a beginner because we're kind of starting over. I wrote a policy on sepsis, and we created a screening tool that is going to go from the ER to med surg, and putting out more education so that we can improve our sepsis scores and our patient outcomes. We do have like a standing order, but it's not utilized. The tracking tool that we had previously wasn't really utilized, so we're kind of starting over.
Sure. And what organization are you from, Kaylee?
Memorial Community in Blair.
Oh, okay. Very good. Very good. So is that something you've pulled a team together to start work on, or what are your next steps?
Yep, we're pulling a team together and deciding, we're kind of, a few of us are owning it, kind of deciding like it's going to be work with the ER and med surg, because that's where the problem is going, patients that are coming from the ER to the floor is where we're missing steps. they're really
Okay.
good about, screening a patient in the ER that they are septic, but we're missing things when we are transitioning the care.
Mm-hmm. Very good. Well, that is awesome that you're recognizing kind of where that gap is and going to work there. So let us know if there's anything we can do to assist you in that process.
Absolutely. Thank you.
Thanks. Next is Kendra. She says intermediate, room to improve, but we do have an order set and have been doing audits and work closely with the septic patients. Kendra, is there anything additional you want to share about what you guys are doing?
I do just want to say we work with Cerner. So we get the sepsis alerts, the sepsis screenings fairly regularly, which is nice. I was going to start maybe doing an audit on, because sometimes the patient, those alerts, they come up fairly regularly. So I wanted to make sure that we're notifying the providers quickly and efficiently on that. So that's something I decided to look into since this has started. Other things I've gained from this would be standing orders, like putting a bolus of fluids on there. We do have sepsis order sets. So we do a sepsis audit every 6 months, and we look at when the labs are being drawn, when the antibiotics are being started. But someone had mentioned trending lactic acids if they've been greater than 2. So that's something we might start changing in our order sets. But because of Cerner, I think that there has been, our facility does work closely with sepsis, and I feel like we're doing well with that, but just there are things that we can look in and improve on, so.
Absolutely. So when you get a sepsis alert, does it just come up on the patient chart when you open that chart, or does it is it like push out to someone?
So usually it's when labs have been drawn or vital signs have been entered, and it is like a pop-up alert. So you're already usually on that patient's chart, but even if you're in a different chart, it'll still pop up. It'll pop up if the provider's on their screen as well as the nurses. Right?
Mm-hmm.
Yeah.
Just based on what's
Very
documented.
good. Very good. Awesome. Thank you. I think it's Brenda Holscher, right? It says intermediate sepsis surveillance in Meditech for positive screens, admission, and every shift screening, annual sepsis education for staff, monthly multidisciplinary copy meetings, tracking increase from, oh geez, you got lots of cool stuff going on. Increase from 48% to 65% compliance in 2 years. That's great. We did provide sepsis education to our outlier facilities as well. Great project. That's awesome. I won't make you because you shared a ton, but if you want to unmute and share anything else, we'd be happy to hear from you. That's great work.
I was going to say, I took a role from ICU educator over to helping out with quality. So the last couple of years, I have had a little bit of a hand in our sepsis changes here at Kearney Regional, and we use the NHA booklet as well. And then I worked with Andrew, actually had a phone call with him. His name was brought up in conversation. So he had sent over some, things that they were doing in an algorithm. So, some of those things we had gotten from there, which we're really grateful for. And then just with the tracking, we found that, 88% of our patients were coming in straight from the ER. So we knew, okay, well, that's where our focus really needed to lie, is getting those bundles down there. And, we have a great physician champion in the ER. They're probably at, I would say, 95% compliance with using order sets. So we've been blessed that way. And, we had a little bit of a dip mid-year, and so started doing those monthly copy meetings just to get on top of things before, they become an issue. So, but it's really been such a team collaboration, even with, the surveillance that was new for us. And we don't get alerts. It is just based on what the nurses are putting in the system. So that's a little bit different, but it would come to me and it would come to the provider to see those. So it's not perfect. Again, we have issues with that communication between ER and the floor for sure, missing vital signs or whatever the case. So that would probably be our big impact there. but we did like a CEU presentation and in a lot of different areas, but one was sepsis. And so that was kind of fun to provide. And I have a great education PowerPoint too, if anyone would like to use it, that we had put into HealthStream for our staff too. So.
Oh, that would be awesome. Yeah. Thank you.
Yeah.
All right. Anybody else want to share about what they've done, what they're going to do? Okay. Well, I feel like we can go to the next slide, Amber. We kind of already talked through this slide. There's kind of what we just talked through, but I guess something for those of you that have spoken or maybe have not, what are those? So we talked about kind of the compliance of using the bundle. Are there any other data points that you're tracking that help you know if you're, those, you know, are you screening regularly? Are you those kind of things? Is there any other key data points that you're using that you feel like are really important to the success of your program? And if so, how are you getting them? Are you manually tracking that? Is there something your EHR could tell you, or how is that kind of collected for you? If it's something in addition to what we already talked about. I feel like you guys talked a lot about your data collection, but I sometimes think that's hard for people to maybe wrap their arms around what data is important to collect and how to get it.
This is
Nothing
Amber.
else?
I know that
Thank you.
sepsis is kind of an ongoing project since it's always a hot topic and it's always changing. So does anyone want to share, is this learning cohort, was it a new project for you? Did you just kind of augment what you currently are doing and make some small changes? Just share a little bit more about where you were at the beginning to now.
Any takers?
This is Jenny from York, and I had not participated in a cohort like this before. And what it did for us was, and I was the only one from York General that did participate in it, and I took the information back to our team. What it did for us was, since we were maybe a little bit ahead, it just kind of confirmed that what we were doing was like I guess the correct direction. Like what the other hospitals in the state were doing. So I appreciated it. And I guess it just confirmed that we were using the right process to move forward and probably having the same struggles that the other hospitals were having too. So I appreciated it, for the 1 hour, and being able to do it virtually, I think was a good learning tool for us, and it was very helpful.
Thank you. Anybody else have anything they want to share on that front? Or maybe even next steps? What are we've kind of gone through the key pieces. Are there next steps that are coming or going to work on or going to continue to work on?
Hey, Dana, this is Andrew.
Hey.
Hey. Well, I think one thing that recently just came to our attention in our quality department between myself and our senior quality analyst was just some of the new changes that came out for this year with regards to fluid bolus administration. Because I know that's a struggle for most facilities in terms of getting fluids to patients. And so with some of the updates and changes, I know we'll be monitoring that even more closely than we were before. And for those people that may not be aware of some of those changes that came out with providers being allowed to include reasons for not administering fluids, and how that's going to impact some of our data in a positive way, and hopefully overall compliance with the SEP1 measure.
And are there specific reasons is there a limited number of reasons they can give for declining that bolus, or is it as long as they document something, they count it?
Yeah, I mean, the major ones, chronic kidney disease or renal failure, congestive heart failure. Even if they document, patient responded to a lower fluid volume, there are some like very specific ones, and then some more broad statements that they could use. But yeah, I would just encourage anybody who hasn't taken a look at some of those new updates to scan through them, so that as you're doing some chart abstractions, whether it's you doing them or somebody else in the quality department, that you're not missing that stuff.
Very good, thank you. Any other thoughts? Anybody else?
I was just going to mention that they just had that webinar for the 5.11 version change, and I thought that was actually really helpful in explaining those fluid changes. So I think that's on QualityNet as a webinar if anyone wanted to listen to it too.
Okay, maybe I can see if I can find the link and send out. Any other thoughts? Does anybody have an aha moment where they were kind of working through something and figured out, oh yes, this is working, or a barrier that they ran into that they would want to talk about how they mitigated that barrier roadblock? Whether it's, I know some people run into medical staff kind of more set in their ways, or even like nurse-driven protocols. Is that something that helped move the process along? Those kind of things. Any big wins, or even little wins, or barriers that you, or maybe you can't address the barrier. Maybe it's something you're kind of stuck on.
I know Saunders mentioned that they moved to Cerner last week, so I think that transition and just EMRs in general can kind of be a barrier, whether it's that order set or that sepsis alert. So just building that to make it useful for your team and meaningful, I guess, is EMRs are oftentimes a barrier in more ways than we like to admit.
Or has anybody seen like alert fatigue, where so many things give you a sepsis alert that people kind of dismiss it without addressing it? Has anybody run into some of that? Or does it force you to address it maybe? Quiet.
Hey, Dana.
Yep.
It's Andrew.
Thank you.
Yeah. No, I think that I guess I don't know if it's an aha moment necessarily, but just maybe a tip for everyone as you're, in early stages of putting together a sepsis program, or maybe you're in the intermediate to expert. I just think that like providing timely feedback is really important. And I know that's maybe not possible for everyone depending on your other duties as assigned, but trying to get as much real-time feedback as possible, I think is helpful. Just so that people are aware of some of the things that they might be doing well or might be missing. Because if it's something that you're only kind of paying attention to, intermittently every once a week or something like that, I just think like some of those opportunities to reach out and correct things or address things, the further you get away from it, the harder it is to maybe hardwire some of that stuff.
Absolutely. And I loved, I think it was Jenny that noted the VA called back on a patient. And that's something too that I always think is useful if you transport a septic patient, just knowing from that tertiary care organization, were there things we could have done better? Were there things that, we did well, so that the staff knows how the patient did and things that they could potentially do better or to continue to do. So I always think that feedback, and not for it to be a shame on you, but just really to improve the care patients get. All right, we can go to the next slide. So this just kind of talks about what we will do next. So as those of you that fall in that beginner stage, that the key thing is really getting a screening tool in place and then auditing that process to make sure it's being used consistently. And then also, along with that, educating your staff on the consistency, so that screening tools can be slightly subjective sometimes. So just making sure that everybody, kind of has been trained in a similar fashion, so that when we're screening patients, we are screening them in the same way. That annual training, Kearney Regional stated maybe they had a PowerPoint they would share. Otherwise, a lot of times if you use like a health stream or something for your annual education, there's education built in. Really just making sure people keep sepsis front of mind. The more and more prevalent it becomes, the more important it becomes to think of sepsis. I don't want to say first, but to always think of sepsis. Keep it in the back of your mind. Think of it, screen for it, watch for it. Another thing that's important is I'm really educating patients and families, whether it's community education or educating them when they're in your facility about what sepsis is, the care of sepsis, and even post-sepsis, potentially post-sepsis things that you will see. And then we talked a lot about partnering with, whether it's your local skilled nursing facility, whether they're part of your organization or they're just in your community. And EMS, I think a lot of times, EMS are your first eyes on your patient. And there's some really simple screening things that you can educate EMS on when they pick up a patient. And then you can have a heads up before the patient gets to your ER so that you're prepared with the things that patient will need right away. So that's something that I know, like through trauma, when we did trauma designation and moving on into other things, really that communication with EMS so that when they call in about a patient, again, you're speaking the same language, and to increase that continuity of care is important. So that's something I would recommend working with your local EMS on too. And then it's also very important to share your data and your success stories with the team. As Jenny mentioned, the VA calling them, I think if there's a way even to do like a case study or an RCA on some of your septic patients, and an RCA doesn't always have to be because of an error, it can be because of a great outcome and just wanting to replicate that outcome each time. So especially where sepsis in a critical access hospital often is few and far between, talking through those with your team and maybe noting if there was a delay, why was there a delay, and what can we do to potentially address that next time, and those kind of things, and talking through those successes is important. Is there anything else that people are thinking either they want to implement and need some additional support in, or that are going to be key to them moving forward in their work? Everybody talked out?
Hey, Dana.
Yeah.
You can always count on me to provide some input.
Well, I'm so glad you got on today. Thank you.
Yes. No, we've done it in the past. I think I mentioned it during one of my presentations. I think it is helpful if facilities haven't done this in the past. I do think it is helpful, the partnership, or at least just reaching out and educating skilled nursing facilities. I think that that right there is something fairly easy, low hanging to educate staff at those facilities. Or if your facility doesn't have like a specific EMS education night. I know here at Mary Lanning, we offer different education nights for EMS. And I think I mentioned it in one of mine that I just have combined stroke and sepsis kind of in one evening, so that they at least get that annual education. But I think both of those things are really helpful, just because we do see a fair amount of patients from our nursing facilities. And it's important for EMS to recognize those like early signs while they're dispatched out, and then calling those patients into the ER.
Pretty good. And that's what, when I worked in Lexington, we did the same. We would go to the local EMS, a group of us, and do education quarterly and on different topics. So I think that's, and it worked well. And it just improved the communication in general. So I think that worked well for us as well. Jenny, did I see you unmute? Did you have something else to add?
Yeah, I put it in chat.
Oh,
We
sorry.
do of course, we do patient education when they're patients, but we wanted to do more like community awareness, on sepsis and maybe some signs of sepsis and when they should seek help. But we also didn't want the community to think, oh, patients that have been at York General have a problem with sepsis or post-op infection or anything like that. So we just haven't maybe done as much as we think we could. So that would be maybe something we would look at doing next, just so that maybe they understand that sepsis could be from any hospital they're dismissed from, or it doesn't have to necessarily be related to hospital care. So that's where we're kind of struggling, is community perception and also community education. So.
That makes sense. Thank you. Anybody else? Okay, next slide. So you can reach out to Amber or myself if you can think of things that we can help you. I'm obviously not the sepsis expert. I'll call Andrew when you call me, but if there are things that we can help coordinate or connect you with, we'd be happy to do that. If you have it can be more specific than just sepsis in general. Obviously, we kind of covered sepsis in general, but if we're seeing, something, even like new measure sets, new requirements and bundles, those kind of things. If you think of things, and I'm speaking to sepsis now, but again, in general, if there's things that you're just like, I need to know more about that, holler at us, because that's really our goal, is to connect you with those resources. Site visits from our HQuick team, we're happy to come out. Sometimes if you have maybe a barrier of getting clinical staff on board, hearing it from an outside source is a little bit easier. We're happy to come speak at your meetings. Again, I'm not an expert, but I can sure gain knowledge through the experts and bring it out, and be happy to help where we can that way. Tools and resources, our next slide kind of gives a few of those, but like the sepsis toolkit, something that we, I coordinated and created, but definitely the information in there comes from the experts out there. Just put it in one place so that people have a simple tool to use. Those are available on our website, as well as if you want an actual booklet copy, let me know. We can mail those out to you too. And we can mail as many as you want. If you want one for your entire team or however you want to do it, happy to send those out. So that's another option. And then data collection and monitoring. So just thinking through that, those of you that are involved directly in the HQuick and the data collection piece, we do some self-reported measures, and our goal is really to make those measures meaningful. So as we look into moving through this project, maybe some of the measures aren't as useful as others would be. So if there's some topics that you'd want to put in, because the other thing it helps with is benchmarking against your peers. So it helps yeah, we are at 65%, but is everybody else that's working on this at 75% or whatever it is? And granted, improvement from your baseline is super important, but also knowing where do we want to get and what goal are we setting is important. So just know that's something too you can reach out to us about, is, what data do we want to collect and how can we collect it and those kind of things. So as you guys continue on your journey, and we're very excited that you are, and we're excited to hear that this was maybe helpful in the kickstart of that, or to just fill in some of the gaps of a program you've worked really hard on already. On August 22nd, we will do a 6-month follow-up, which is something we do with each of our cohorts. And hopefully during those 6 months, we'll see COVID in a lull, and you'll be able to really work on some of those key indicators that are important to your organization. And we'll come back in August, and really it's just going to be a quick touch base. What have you done in the past 6 months? What can we do to help you as you move forward? And what additional things can we put out there to educate you or your staff? So be looking for that meeting invitation coming out soon as well. Next slide. So these are just links to some additional resources. And these slides will go out to you, or I did send them out already, I guess, but I think the NHA Sepsis Toolkit we added last minute, like we forgot ourselves at the end of the list. But again, those will be in the slides. The recording and all of the slides will be on the website as well. But there's always tools and resources, and Andrews in the world that are willing to help. Jenny, who has been working on this for some time, you know, a peer critical access hospital is always helpful. Our other speakers that have spoken throughout this cohort are willing to help too. So never feel like you're stuck or alone. There's always going to be somebody out there that's either worked through it or is working through it, and we can support one another. So don't hesitate to reach out to those. That's the best thing about Nebraska Healthcare, is the sharing and the collaboration that we have. Next slide. I think we're about at the end. Yeah. Does anybody have questions, comments, additional information that they want to share? All right, hearing none, you guys get 13 minutes back on your day. If you do think of something you need, don't hesitate to shoot an email to myself or Amber or anybody else that has been involved in the cohort. And we look forward to hearing all the great work you've done in the next 6 months. So thanks, guys.